Hi, I'm Dr. John Martin with Ivy Family Health Updates, and I'm here today with my brother, Dr. Edward Martin, my sister, Dr. Catherine Martin, and our special guest, Dr. Manjula Jesgosothy. Now, Dr. Jesgosothy is a graduate of Harvard University and of the University of Pittsburgh Medical School. She then went to Yale for an internship in internal medicine, followed by a residency in dermatology at the University of Miami. She's a world-renowned dermatologist, and I've heard her speak at many different meetings, and she works here in Miami, has a thriving practice, and we're very happy to have her here today to talk to us about melanoma skin cancers.
Thank you very much, Dr. Martin.
Great to have you.
Melanoma is actually the most deadly form of skin cancer in people under the age of 40. And it's very common. It's much more common than people think. You know, in a busy dermatology practice, we diagnose 1 or 2 people every month. And so it really needs to be something that people really are vigilant about and stay on top of. Melanoma is a skin cancer compared to the others, which has more of a genetic component to it. There is a good deal of sun exposure related to it, but since it happens in younger people, we think that it's for the most part genetically determined.
Do you think, can the sun be a primary cause, or is it more of just an extra stimulant for those abnormal cells?
We think it's just an extra stimulant for that genetic composition of a certain person. Okay. And so, how do you know if your moles are normal or abnormal? The dermatologists have a system called the ABCD system of looking at your moles. Each letter stands for a certain characteristic of your mole. So A is asymmetry. If you have a mole that's not perfectly round or not perfectly oval or is asymmetric in any way, that's a risk factor for it being abnormal. If you have a mole that has a jagged border, that's B is for border. If it's not a completely straight, well-demarcated border, if it's jagged in any way, that's also a risk factor. And then we say color, C is for color. If there's multiple colors within your mole, or if your mole is either red, white, black, or blue, like the American flag, black. Those things are bad, so that's another risk factor. So any multicolored mole is something you should follow. And then D is diameter. And diameter is greater than 5 millimeters, meaning larger than, we say, the head of a pencil eraser. And so any of those risk factors, if you have a mole that has any of those things, I recommend you seeing the dermatologist. If you have a mole that's rapidly changing over the course of 2 to 3 months, if it's bleeding, if there are any symptoms associated with it, in your children, certainly their moles are going to grow, but if they're growing faster than the child is growing, we always say that's something that needs to be addressed by the dermatologist as well.
Now, do you have to have a mole from birth to develop a melanoma?
No, that's actually a common misconception too. Most of us are not born with all of our moles. Our moles, they're there. They're genetically they're there, but they often manifest with hormonal stimulation in our 20s and 30s. Sometimes they grow outwardly. And certainly there are other growths that we get as we get older, which people think are moles, like keratoses, which are not moles. But most of us are not born with the moles we end up with later in life. So that's another reason. If you have something that's new, it's a good idea. If it's new and it's black, it needs to be seen by the dermatologist within 2 to 3 months, I would say.
Now, since there's a strong genetic component or genetics risk factors, once you diagnose melanoma in someone, do you evaluate family members, or is there some sort of screening process?
I do. I tell anybody who's been diagnosed with the melanoma, their first-degree relatives, meaning mother, father, brother, sister, or child, are 9 times more likely to develop a melanoma in their lifetime. So I do get all the first-degree relatives in to see me, or wherever they live, to see the dermatologist, because I think that is an important screening method. Another risk factor, which is not part of the ABCD system, is having multiple moles that are of varying shapes and sizes. And sort of people who have that sort of predilection, most of us now as dermatologists send for a specialized consultation called mole mapping. It's a computerized digital system that is available at most of the university centers, most of the cancer centers. where these types of patients can get each of their moles individually mapped, and then the computer actually judges its probability of turning into a skin cancer based on a complex algorithm.
If you've had one, is there a good chance you're going to have another at some point?
If you've had one melanoma, in my opinion, you should go and get mole mapping.
Okay.
I think that there's a very high likelihood of you getting a second one, particularly if you're young and it's caught early. I think it's a very good idea. Melanoma kills. We don't have a great cure for it. So,
yeah. You want to tell us the treatment? What treatment is there?
Absolutely. You know, the treatment, the standard of care right now is doing a very wide excision of the area. So inevitably you end up with a big scar and that goes all the way to the muscle. So it can be quite disfiguring depending on where it is. And you know, if nothing else, it's debilitating during the recovery period of the surgery. There were some promising studies in the early 90s with interferon. That's turned out to be not as good as we had hoped. Certainly it's helpful in some people, but certainly hasn't been as good as it is certainly in hepatitis C or some other diseases that it's very good for. There are some promising new studies being done with vaccines where the person's own melanoma cells are taken and made into a vaccine, and then it's injected back into the person, and that has been probably the most effective thing we've seen so far, but it's very expensive. It's all out of pocket, and you know, that's probably coming up for the future.
Can you also go over for me what do people die from when they have their melanoma?
Melanoma is extremely metastatic. It's as metastatic as breast cancer, if not more so. So if you have a melanoma that's even slightly deeper than skin level, it has a very good chance of having metastasized to another organ by then already. Okay. And that's not really readily seen on a CAT scan or anything like that. So you just have to be very vigilant with going for your checkups. If they're past a certain depth, in general, we do a node biopsy of the area where the node drainage is in that area. So if your melanoma's on your leg, you might get your node sampled in your groin. Okay. If the melanoma's in your upper body, you might get your node sampled in your axilla. And that has a very good prediction factor for whether you're going to have recurrence or whether it's already spread.
And if it has metastasized, do we have any chemotherapy for?
And the chemotherapy agents are not so effective. I mean, 5-year survival rates on node-positive melanomas are still very low.
Okay. So,
prevention.
Not good.
Prevention, and certainly getting in as soon as you see a mole that you think is funny, is getting in and seeing the doctor, because, I mean, really it needs to be biopsied. And we, as dermatologists, you know, if something looks funny, we biopsy it right away.
Right. All right. So, very important to remember that at home. You know, any suspicious lesion, you should go see your dermatologist and have them take a look at it.
Or your primary care doctor. I certainly see a lot of patients who've been biopsied first by their primary care doctor. So.
All right. Well, great.
Thank you.
Well, thank you.